Thanks. So I'm going to be talking a bit about public health and the kind of interesting things that we're doing to kind of move forward. But just quickly, as a show of hands, how many people have heard of Change for Life? So if you put your hands up. Okay, that's pretty good. So I would say I've had equal amounts of people say to me, it's brilliant, love the yellow. And equal amounts of people say to me, what were they thinking? Like, it's too yellow, there's characters, etc. And so hopefully by the end of this talk, I can show you a bit about what we were thinking, and actually there's a bit of thought that's gone into that, and there's some stuff that makes it really successful. But starting with Public Health England, so Public Health England as an organisation does lots of different things. So it does things around developing vaccines, infectious diseases, and so on. But I'm not an expert in any of those things, and I work within the marketing team. And so the marketing team basically tries to improve public health behaviours, so to prevent some of the things which are preventable. So in England, 60% of ill health is actually preventable and caused by lifestyle factors. So we try to get people to change their behaviours around those different things. And we have a really strong focus on inequalities. So again, within England, what you find is that the lower socioeconomic groups tend to have the worst behaviours in terms of health, and then therefore tend to be more susceptible to cancer and diabetes and all of those things. So a real focus on inequalities and getting the hard to reach to act. And broadly, we break our work into 3 life courses. So starting well is basically our young people's campaigns. So we have things around breastfeeding, weaning, so kind of for early mothers. We have Change for Life, which is around childhood obesity. We've got Talk to Frank, which is around drug use. Rise Above, which is all around youth prevention. Then in Living Well, we've got our 1U brand, which brings together a whole range of different adult health behaviours for adults. We've got Dry January, Stoptober, Active 10. And then in Ageing Well, it's often to do with health protection and appropriate use of the NHS. So we've got things around early detection of cancer and signs and symptoms of stroke. So I'm going to touch on a few of these examples as I go through my presentation, but feel free to ask me about any of them during the questions or afterwards. So just a couple of examples of how we're using behavioural theory within the campaigns to make them more effective. So for Stoptober, it's about getting people to quit smoking in the month of October. And actually we know that social norms are really important. And so through Stoptober, it allows people to set themselves the challenge and actually say to their friends in an acceptable way that they're quitting during that time, and trying to make it a mass movement so that people are quitting at the same time and are therefore more likely to support each other. And that's been really successful in getting over 1.5 million people to try to quit smoking during October. Then self-efficacy. So again, with our lower socioeconomic groups, what we find in our research is that actually they say, I don't feel like I have control over my health. Health is just something that happens to me. Nothing I could do will actually make a difference. And so with our 1U campaign, what we've been trying to do is raise self-efficacy, and it's all about simple steps that can make a big difference. So things, for example, like telling them that a walk for 10 minutes, if they make it brisk, can have an impact on their health so that it's easier for them to switch. Then choice architecture. So we know that decisions are affected by how people are framed, how they're framed to people. And so one way we've done this is through working with the online retailer, My Supermarket. And within that, we've put thumbs up badges to products which are healthier, and we've had swaps so that if they try and put something unhealthy in their basket, it offers them a healthy alternative. Then hyperbolic discounting. So we know that people value the present more than the long term, and they assume that in the long term things won't happen to them, and so they deprioritise that. So therefore our cigarette advertising, so our health harms, is all focused on the damage that every single cigarette is doing you right now. So to put that right in the present rather than in terms of long-term health. Then with heuristics, so making it easy for people to remember things. So for our stroke campaign, it's all around ACT FAST, so FAST being an acronym for face, arms, speech and time, in order to help people recognise the signs and symptoms of stroke. And then chunking, so trying to make big tasks into smaller ones. So both for our adults and for our kids' physical activity campaigns, we've made them around 10 minutes, so allowing people to realise that actually even 10 minutes exercise can have an impact, because what we've tended to see in research is that people say they don't have time for exercise, so making it really easy for them. And so in terms of our process for planning campaigns, so this is very similar to a lot of processes, to a social marketing process, to the OASIS framework from government. And so what we do is look at the policy driver, see where the kind of biggest issues are, where we should be focusing, then set objectives, do lots of audience work to understand the audience, and then come up with strategies, do implementation, make sure we do ongoing monitoring in order to improve the campaigns as they're running, and then obviously scoring and evaluation. So what I'm going to do for the rest of the talk is just tell you a couple of different examples within those areas to show you some of the interesting bits that we're doing. So within audience, strategy and implementation, and in evaluation. So understanding audiences. So I think for us, the real challenge in this area is understanding slightly less conscious barriers, because when we do qualitative research, people tend to tell us about the rational aspects of it, and they often can't tell you the reasons that they did things, or they can't remember. So they might overestimate, for example, how much physical activity they did, or underestimate how much they ate. And also getting to some of these kind of more emotional barriers is really important for us, so that we understand the rational versus the subconscious. And I think it's also really important for us so that we can design campaigns which are likely to work. So what we've tended to see is that when we've tested kind of creative development, if you test it using qualitative research, that can tell you a certain amount, but people tend to tell you what they like rather than what will actually change their behaviour. And so we've tried to look at how we can actually go further than that. So one of the ways in which we've done this is through ethnography, and we've done this within all 3 of our life courses. And here we've asked people to basically wear a Google Glass for a day or 2, and then recorded what their daily experiences are. So I'm just going to play a video from it, and I'm sure we'll all recognise ourselves slightly in it.
Grab me a bit of cheese. Any cheese will do. Well, I'm not wasting it. Thanks, lover. A bit of cheese would have done, lover. That's a bit of cheese, isn't it? I love cheese. I can just, no matter what cheese you put on that board, I will eat. Yeah.
Let them have it.
I don't mind, don't go here.
Yeah, rather than.
I'm eating somebody else's cake as well.
I think that's cake.
So I think you can all see that actually, you know, that we all see that behaviour in ourselves. And I think what's really helpful about the ethnography is if we had just spoken to that man in qualitative research, he probably wouldn't have admitted to that or even noticed it. But it's something which we can actually see. And so we saw other things, for example, like people hiding the fact that they were smoking and smoking in sheds, or the conversations that they would have with family members who might be nagging them to change their health behaviours. And so through kind of our ethnographic approach, that's really helped us to understand more about the context of people's everyday lives and how health behaviours impact them. So another one, so with our antimicrobial resistance campaign, so it's all about keeping antibiotics working for the future. So what we found when we did quantitative and qualitative research is that doctors would say, people come to the surgery and they expect antibiotics, and you know, therefore I feel like I'm pressurised to give them. And then when we spoke to the audience, what they said is, no, I never pressurise my doctor for GPs. I would never do that. I trust the GP's advice. And so we were kind of like, what's going on here? Which one is it? And so this was an approach that we used. So within qualitative research, we asked people to put different emotions next to how they felt if they didn't get an antibiotic and how they felt if they did get an antibiotic. And what you can see is all the positive emotions are associated with receiving an antibiotic, and all the negative ones are associated with not receiving it. And actually what we realised was with antibiotics, it's all about the strength of illness. So people don't see it as the difference between viral and bacterial. Instead, what they saw it as is if I feel really, really ill, then I need antibiotics. And so therefore, they were going into the GPs and expecting a high value exchange. And therefore, when they hadn't got the antibiotics, even though they may not have realised it, they were feeling kind of negative emotions associated with it. And so therefore, it was quite a strong emotion that was going on. And then semiotics and digital forensics. So this links to some of the cancer work that we've been doing, and actually to one of the questions that was asked earlier. So what we found in some of the qualitative research around cancer is people do talk a lot about not being aware of symptoms, just delaying, just taking a wait and see approach. People often talk about, I don't want to bother the GP and I don't want to take up NHS resources. So what we did this time around is actually, so we complemented our qualitative and quantitative research with some other types of research methodologies. So we did digital forensics, which basically means we scraped 500,000 for posts on forums, on cancer forums, and then used some algorithms to look at some of the themes that were going on. And it both used a computer to analyse it and then also a human going through it to see what the themes were. And then we also looked at semiotics, so what's the public discourse around cancer and what does that mean to how people think about it? And what we found is, similarly to the Scottish Government, that actually fear was one of the big things that came up. And so what people were talking about is actually cancer is such a big thing and it's presented in these two extremes. So our semiotics work showed that in culture, it's opposed in these two extremes. So for example, it's either a person suffering in silence or it's everyone together and we have to stand up to cancer. And so what that showed is that regardless, the person is powerless within that kind of debate, and actually it feels like they don't necessarily want to have that battle, because what it was telling them was them with cancer is not them, and they would prefer to be them than to have this all-consuming word cancer put on them. And so that was really helpful to help our understanding in terms of how big the fear was and how we could think about challenging that. So then moving on to strategy and implementation. So I think within this, we've seen over the past 10 years the kind of opportunities through digital, through targeted media and so on. And I think here the real challenge is how do you not create something just for the sake of it, so just creating an app or just using digital communications, and how do you go with where the audience is and make sure that it matters to them and works for them. So Frank, so some of you might know the brand Frank. So Frank launched about 10 years ago and it had a high amount of spend that was spent on it, and so it's become a really recognisable brand. And in recent years we haven't had the funding to be able to spend basically anything on the communications. It's just been a website with some call centres. And what we've seen is there's still been millions of people coming to the website every year, but actually the back end was not really working, and so therefore we had to kind of go through a project to kind of check whether it was still working and then rebuild the website. And what we found is that actually what people said is there's lots more information in the drugs market, but actually if you look at that, there's two extremes, so the establishment or the anti-establishment. So you've got the establishment, which is government and NHS, and all of that is basically saying drugs are bad, and you kind of know that that's what those websites will say. And then you've got anti-establishment, so lots of forums and so on, which basically say drugs are good, and it's lots of people kind of putting their perspective to it. And so what they said was actually Frank sits in the middle really well because it gives you both sides of the story. It tells you what you might enjoy, but also what is the risk factors around it and how to protect against those risks. And so it really helps to meet in that space. With this, when we were rebuilding it, we also did a kind of landscape review. And what we found was there were really interesting kind of new developments in the market. So for example, there's a teenage couple in, I think it's Amsterdam, who try drugs every Friday, a different drug, so that you don't have to, and you can watch what their experience is. And this has millions of views. And so also looking at the youth audience, we saw that YouTube and kind of video was a really big thing. So we were thinking, is that something that Frank should be doing? Should it have more video content? And actually what we realised is that actually it wasn't really where it needed to go. What people did is they would search for information about drugs, find the information from Frank, and then they would go away and maybe have a little bit of a browse. But it was very transactional compared to other websites which were a bit more edutainment or educational in that sense. And so through doing that, we really rebuilt the website in a way which was just focused on that transactional element, so making sure it was very good SEO and so on. So it was actually what Google said was one of the best website relaunches they've ever seen, and it had a 47% uplift in people coming to the website just through improving the SEO. So in terms of personalisation, so this is something which obviously we do have a lot more opportunity to do. So people talk about it as now becoming about mass one-to-one communications. And so how we've tried to do this is through some personalised content. So examples we have here, so is a personalised quit smoking plan. So during the month of Stoptober, in previous years what we saw is that actually people were trying to go cold turkey and stop without any support, whereas actually all the evidence shows that you're more likely to be successful if you quit with support. And so the personalised action plan was a quick way for them to find out what might be the right tools for them and give them some guided support. Our other quiz is How Are You?, which basically is around all adult lifestyle behaviours, and people can do a quiz and they get a score, and people are really interested in seeing how they're doing, and so that helps them to actually act based on it, and tells them which areas they might be worse on and which areas they could improve, and then guides them to further support. And then also we did a campaign which was called How Healthy Is Your Heart? So it was the heart age tool. And people were, again, quite interested to see if their heart was older or younger than them. And with very little media spend, and actually just through a lot of PR, we were able to get over 2 million people completing it on the first day. And so with some of these tools, you can actually see that if you can get that nugget of making people interested in their own health through personalisation, you can get millions of people completing it. Another tool that we've come up with is the Alexa Breastfeeding Friend. So this is a voice skill, so people can talk to it to help support them around breastfeeding. And so the idea behind it is obviously that it's a bit hands-free and it makes it easier for mothers. But actually the really interesting research from doing the audience insight work and then the evaluation was actually that for the mothers who were using it, actually they felt that there was some judgment around not breastfeeding, and they assumed that it was going to be easy, and no one told them that it was going to be harder than, or it needed some work. And so actually what we found is that actually this was a way in for parents, because they felt that they didn't necessarily feel that the digital voice assistant was judging them, and so they could ask it really honest questions. And then for those of them that it did manage to support, some of them managed to solve their queries, but then for other ones it helped them get further support. And actually, so from an audience perspective, it wasn't about it being digital, it was actually about the fact that they felt kind of embarrassed, and this allowed them to not be embarrassed and to talk about it. And then targeting. So there's lots of opportunities with targeting, and so we've tried to use this in different ways. So for example, for our mental health campaign, what we've tried to do is look at things, for example, as what time are people on the scrolling through their Facebook feed. If it's at 2 a.m, maybe they're struggling with sleep, and so you can serve them content around sleep. We can also look at things like their lifestyle behaviours, what they're doing online, and then also how they're interacting with our content in order to be able to target them more appropriately with the things that might be relevant to them. So whether that's action-based or whether that's focused on anxiety or depression or low mood and so on. So then thinking about evaluation. So I think the challenge here is really, compared to traditional marketing companies, when you run a marketing campaign, you can look at the sales for your product, and that allows you to see whether your marketing campaign has been successful. For us as social marketers, it's a lot more difficult because you don't have direct access to witnessing when that behaviour is happening. And so you therefore have to use other measures. And obviously there's qualitative and quantitative research, but as we all know, we get reporting bias. And so we try to think about how can we go further to make sure that we're actually looking at real behaviour rather than just claimed behaviour. So one of the ways in which we've done this, so these are 2 examples from Change for Life. So what we did on the left-hand side is that during one of our Change for Life campaigns, so we matched 30 Tesco stores based on their previous sales data, so based on their sales of diet drinks, and also sugary cereals. And so for the 6 weeks prior to the campaign, we saw that the sales was basically following each other between those campaigns. They were kind of matched stores. We then showed the creative at half of those stores and then didn't show it at the others, and it was all about a sugar reveal, so revealing how much sugar is in a diet drink versus a fizzy drink or in sugary cereal. And then we looked at the difference between the test stores and the control stores during the time period and then following the campaign having ended. And what you can see is that actually there was a deviation, and so during the campaign period and then also afterwards, the shopping in the stores where we had shown the creative had changed, and people had switched to healthier things in their basket compared to in the control stores. Similarly, so I talked about with my supermarket how we've been partnering with them to show Change for Life creative, suggest swaps. We also have a sugar accumulator, which means that when people put things in their basket, they can see how unhealthy or healthy it is. And so with this, what we did was we did an A/B test. So 80% of people that came to the My Supermarket store saw all the Change for Life communications and the creative, and 20% that came didn't see anything, so there was nothing related to Change for Life. And then we were able to look at what their basket data was and nutritionally, and so you can see the difference between the salt, saturated fat and sugar in those baskets and the 2 to 3% difference in each of those areas based on the people who saw Change for Life creative versus those who didn't. So it was a really rigorous way to actually see if people were changing their behaviour. Another thing that we've looked at is neurotesting. So this goes down to the point of actually people not being able to tell you what necessarily works from a creative point, or if they do, they might tell you broadly what is going on, but not the kind of detail of it. And so this was, we did this after we'd run our pilot of the antimicrobial resistance campaign. And so what you can see here is that there's the red and blue line, and basically the higher it goes, the better. The red line, I think if I can get it right, is the detail line, so whether they're paying attention to the detailed messages, and the blue line is whether they're paying attention generally and kind of listening to the kind of overall message of it, and see if you can spot what's going on here.
Antibiotics, we're wonderful pills, but don't ever think we'll cure all of your ills. So every time you feel a bit under the weather, don't always think that we can make you better. Take us for the wrong thing, that's dangerous to do. When you really need us, we can stop working for you. So please don't end up paying the price. Always take your doctor's advice.
So what you might be able to see is that actually during the moment, so people start paying attention at the start, they're kind of like, oh, this is a nice song, I'm going to pay attention to something which could have been an otherwise boring message. And so they do start paying attention. But then at the key point when we talk about personal risk, which was the most important proposition for our campaign, people stopped paying attention. And actually at the call to action at the end, again, it drops. And so you could see from that actually what our key messages weren't getting through. And what we realized is because of the way in which the music, the picture and the song and the detail of the wording within it were working together, that was stopping people from paying attention. And so we were able to change the creative slightly in order to get people to pay attention at the key points. And so that was really helpful in terms of helping us improve for the national campaign. And then, so in terms of evaluating against a model, so Rise Above is our youth prevention campaign, which looks at a whole range of risk behaviours. And so it's based on the prototype willingness model, which some of you might be familiar with. But what this model tries to explain is that actually when you ask a young person, are you going to smoke a cigarette in the next year, they'll probably say no. But actually, when they're offered a cigarette by their friend, they might say yes. And so it tries to look at the difference between those, so between behavioural intention and behavioural willingness. And so the key difference is that actually behavioural intention is whether they intend to do it, and often they don't intend to do it, but actually they are willing to engage in that behaviour, and that is why when they're offered a cigarette, they actually act in that way. And the core determinants that make a difference to that is personal vulnerability. So this is not them thinking or knowing the fact that in the future 50% of people will get cancer. It's them thinking personally, if I smoke this cigarette, something bad might happen to me and I might get cancer, or I might embarrass myself in front of my friends, each of which can have an impact. Then there's subjective norms, which is, or social norms basically, which influences intention, because if their peers are smoking, they might be more likely to intend to do it. But it also influences behavioural willingness, because it means that they're more likely to feel like they should say yes to the cigarette if they're offered. And then risk images, which is basically what they think of the type of person who who smokes or the type of person who doesn't smoke. So for example, if they think that someone who smokes is cool, if they're then offered a cigarette, they might be more likely to say yes in that scenario, because they think that if they say yes or no, it will make them look cool or not cool. And so therefore risk images has a massive impact. And those are really important for behavioural willingness. So our approach with Rise Above is to use influential young celebrities, so vloggers, to talk about them being risk avoiders and say, that they chose not to smoke and they're still cool and that kind of thing. And so to kind of use that as a way to actually build people's resilience and get people to understand that actually risk avoidance is a lot more attractive than they might think based on the current context. But the really difficult thing about evaluating this is if you think about the fact that through a questionnaire, if you ask someone, are you planning to smoke a cigarette? And with young people, they say no, then that makes it really hard to measure, because actually you've got people saying no before and after. So what we were able to do here is basically do a test and control study using a questionnaire. So what we did was we recruited 1,500 participants and we made them fill in the same survey, which asked things related to the Gibbons and Gerard model. And then to half of that group, we sent them content which was related to Rise Above over a 10-day period. And then to the other half, we didn't send them anything. And then we asked them to fill in another questionnaire at the end of that. And we compared the results between the test and the control group pre and post, so that we were able to look at it. And the type of questions that we would ask were things like, how much do you want to be like the type of person who does not smoke cigarettes, does not take drugs, etc. And what we were able to see is that actually there's 10 to kind of 13% differences in some of these areas. So people who actually interacted with Rise Above content were more likely to have shifted their risk images. And because of the literature in the space around the prototype willingness model, we are able to show that actually that's likely to stop them from smoking cigarettes in the future and so on. So coming back to Change for Life, which I mentioned at the start of the presentation. So in terms of the branding, so this has really been carefully thought about. So in lots of our insight work around Change for Life and childhood obesity, what we find is that parents don't necessarily, they understand that childhood obesity is a problem in general, but they don't see it as something that's relevant to their child. And actually, when they receive the NCMP letter, which is a letter that sometimes goes out to parents that might tell their child that their child is overweight or obese, they tend to reject that letter because they think it's blaming them, and actually that it's something that they don't want to be blamed for. And so when you look at the family, actually it's about nobody in particular, it's every family in general. And so that allows it to stop it from feeling like it's blaming people. And again, rather than blaming the individual, it's about blaming modern life and being on the side of parents. And it's not fat bodies, which no one likes in terms of fat shamings, but fat in the body. And so with the careful creation of those kinds of things, that's what's really helped it to work as a brand. But obesity is a complex problem, and so when we've looked at Change for Life, so we have over 90% of people who are aware of it, who trust it, and that's really impressive in the sense of trust in government, business, NGOs, etc. is really low. And so Change for Life has been able to maintain high levels of trust. However, what we see is, for example, I've shown you some of the studies which show that people do make that behaviour change, and actually when we do quantitative studies we get claimed behaviour of around 60% or more. But actually what tends to happen is that people make that behaviour, and we're very good at helping people to take the first step, but sometimes they go back to the old behaviour. And to be honest, that's not surprising. So if you look at the Foresight Obesity Report, so those are all the different influences which affect obesity rates, and you can see it's supposed to look messy because it is really, really complicated. And also, if you think about the fact that there's 27 times more money that's spent on unhealthy food advertising every day than there is spent by Change for Life, for example. And actually, we've done our own study, so we followed 9 children over 2 days, and we saw that they saw unhealthy food advertising 566 times, and of those, 2/3 of those were with characters on them as well. And so you can see that it's a very obesogenic environment, and so what that means is that actually all of these things are shifting and nudging people to be really unhealthy. And actually what the Foresight Obesity Report talks about is that actually in our day and age, in our society, the norm should be to be overweight rather than to be a healthy weight because of all these influences that we're having every day. So therefore, our revised approach in the past couple of years has been about system change. So how do we not just tackle the individual, but how do we also promote culture change or system change to make the environment more healthy? And so the ways in which we do this, for example, are increasing demand for healthier products, so for low sugar products, which what we've seen, for example, since we launched the Sugar Smart campaign, which allowed people to scan items of food and drinks and see how much sugar was in them. And through that, and through demonstrating the demand for it, so over 2 million people downloaded that app, what we were able to see is that actually the industry has started to reformulate more and is more likely to advertise low sugar products because they've seen that demand. And also it's made it easier for policy interventions like the sugar tax. And so within our communications to Change for Life, we try to think about it as what's the behaviour change, but also what's the system and culture change that will help these behaviours to work in the long term, because we will have helped to change the environment around it. So that's all I'm going to talk through today. I've got more information here, so a brochure, and a bit more about how we can support different organisations. So if you're interested, come and see me afterwards, or I think there's an informal session later to talk through. But thank you.